Hello everyone. In this presentation, I'm going to talk about an important question for clinicians, which is how to evaluate effectiveness of treatment. As clinicians, I don't know how frequently this question comes to our minds, or how how much we think this question is important, because we often assume the treatment that we give is an effective one based upon our experience with that treatment. But I want to bring attention to this question, and also I would like to discuss about how not to evaluate the effectiveness of treatment. Also, what are not so correct ways of evaluating treatment. I hope you will see the importance of this question at the end of this presentation. Now, how do we know if a treatment makes our patients better or worse? Uh, like I said, it's an important question, but sometimes it's often assumed rather than actually discussed about. Uh, Two sub questions which I think is relevant for this is that one is the treatment that we provide. Is it working? Does the treatment work? And secondly, and more importantly, whether the treatment that we provide is the best treatment. Best in terms of the available best, because when addressing a patient's problem, we always have a choices of treatment, but we are expected to provide the best available. The patient also expects us that they are receiving the best care. But the question is, how do we know that this is the best treatment? And how do we know the treatment is what treatment that we provide is actually producing the outcome that we intended? Now, clinically, there are three common methods which I think is used for evaluating recovery following treatment. That is, first thing is that many clinicians often rely on preconceived notions about effectiveness of treatment. That is, say for example, what is the effective treatment for Bell's palsy? I've asked this question in a group of audience. Most of them said electrical stimulation. Now, most of them or clinicians were providing treatment. They're given electrical stimulation, and which they thought it is effective, or in their college it is taught to them that this is the treatment for Bell's palsy. So they developed an opinion that this is the effective treatment, and that opinion was never tested against whether is it really true, or looking for evidence and so on. And unfortunately, this is one of the common method many clinicians evaluate effectiveness of a treatment. The second method is we ask patients about how they are doing well. That is, after the end of a course of the treatment or in the middle, we ask patient how you are feeling now, or how well you think you have recovered and so on. And the patients often respond that no, it is same, or I'm getting better, or sometimes rarely patient may also say I'm getting worse. This is the another method we commonly use to understand or evaluate effectiveness of treatment. The third was using an outcome measure. Not so common, but I think a small proportion of us, especially the young clinicians who are just coming out of college, who are currently being trained in using outcome measure, often use this outcome measure, such as visual analog scale for pain or some functional measure before and after giving treatment, and look at the changes in the score to evaluate if the patients are getting better or not. So these are the common methods are used to evaluate treatment. But what I'm going to discuss in this presentation is that all three are are really not an appropriate method for evaluating it. I'll tell you why. Now let us say that what we are seeing clinically, that we are measuring with an outcome measure, or we are asking a patient to recover, or the preconceived notion that we have. Now what we see clinically, the patient improvement is that patient starts from here and there is some significant improvement that is taking place, that we might use an outcome measure after a week or after a couple of weeks. We measure it and shows an improvement in score, and most of us clinically are convinced that the treatment it works, and we continue to repeat that treatment or probably develop opinions that this is really a good treatment and tell others, teach others, and so on. So any of these three methods which I previously discussed is this is what we are seeing clinically and determining. But look at in this graph, what actually that is happening is that there is a treatment effect, but what we clinically often do not consider is the natural recovery of that condition. And everyone must, I believe, must be knowing that a treatment, a condition has its own natural recovery process, often referred to as spontaneous recovery, that the body's healing mechanisms in the internal innate healing mechanism is taking place. So when a patient comes to treatment, that mechanism is already in place, and the patient expects that the mechanism that the treatment can speed up that process or can make that process more complete and so on. But what we see after a couple of weeks of treatment is not just this, but it also includes a natural recovery. Now clinically we can never distinguish, or it's not easy to distinguish recovery that takes place because of natural recovery. But we must understand any recovery that comes after treatment also includes natural recovery. So it is not correct to assume that all improvement that has seen after treatment is only because of our treatment effect. Now, in addition to natural recovery, there is other aspects of outcome also, which is a placebo. I'm not going to explain much on placebo. I assume most of you are well aware of it. It's the patient's expectations which is influencing their perception of outcome. In addition to that, biases. There are lots of clinical biases that we have. Just to give one example, is that we are very much interested in patients getting better. So, but we are the one who is giving the treatment, and we are the one who is also evaluating it works. That is, it is equivalent to we are evaluating our own examination and giving a grade to the examination that what we have done. Now it's a simple fact that if you're in college and you're writing a paper, somebody else has to evaluate. We cannot write and evaluate by ourselves, so that brings out a lot of bias. So this is just one aspect of bias that I've explained, but there are n number of biases that is prevalent when we are doing measurement clinically, and which is often very difficult to control also. So to make that point again, what we clinically see as recovery is this, what we clinically measure patient improvement is this, but not all of this is due to the effect of the treatment. Whatever improvement that we see also includes natural recovery, placebo, and biases. Now the question arises, how do we know that how much is actually this treatment? How can we distinguish how much is because of natural recovery, placebo, or biases? If we know that, then we can actually know that what is the actual extent of the treatment effect. Yes, but clinically we can never know. As some of you might be aware, that a randomized controlled trial or an experimental study is where it is how you can distinguish it. The randomized controlled trial is designed specifically so that it is possible for us to distinguish natural recovery and treatment effect by having a control group. So if you're having another group, means that other group also will have this, so it will be common, which can be cancelled out. And there are lots of measures available, such as blinding and many other ways by which you can control biases. You can measure, you can blind the outcome assessor, and you can randomly assign patients into group. So all of these methods allows us to minimize the biases. Keep in mind, bias can never be totally removed, but randomized control designs or designed in such a way can be minimized. Placebo effect, again, which can be controlled if you're having a control group. So that is why it is not appropriate, or it's not correct to determine effectiveness of treatment based upon what we see clinically alone, because there are so much is in the other aspects, which other factors that can explain recovery, which cannot be observed or measured in a clinical setup. So let me ask you, keeping this in mind, let me ask a question: which one is the best treatment? Remember, we started off saying that as clinician, we have to know answer to two questions. That is, does this treatment works? And if it works, is it better? Right? So we just seen in the previous slide how to evaluate whether treatment works or not. Now the next question is, which one is the best? Now the idea of best is always about comparing it with another. There is no actual definition of the best, but we are talking about best available treatment. So if there are 4 or 5 treatment options available, we have to select a treatment which is the best. Now I'm going to show you how conceptually how the best is determined. So let us see. I'm giving an example of 4 treatment A, treatment B, treatment C, and treatment D. So let us see. This is based upon the same previous slides as I've shown. The yellow means treatment effect, the maroon is natural recovery, green for placebo, and blue for biases. So treatment A is this, treatment B, treatment C, and treatment D. Now look at the proportion of each effect in each treatment, and now tell me which is the best treatment. Now you can pause this video, hold it for a few minutes if you want to think, and then come back and listen what is said. Now if you have guessed it's treatment D, you are right. If you have not guessed it is as treatment D, then you might have to work a little bit hard to understand why it is. Now I'll tell you why treatment D is the best. As you can see, the treatment effect is the highest in here. The actual treatment effect is highest in here. I believe all of you can understand that natural recovery is not something, it is common across all treatment. The proportion of contribution to recovery to the outcome through natural process is common. However, the treatment effect, as you can see, treatment A has the lowest treatment effect, treatment B is slightly more, treatment C slightly more than A and B, and treatment D is the highest. So ideally, we will select a treatment that has a treatment effect or the specific effect of treatment having higher levels. Now this is how we can determine, right? Now this understanding appears fundamental, I would even say elementary, but unfortunately this logic is often not applied. Now I'll tell you why. When somebody comes up with a new treatment, or you hear that there's a new treatment has come up, and we often go for it without asking for such data, that we are all, let us assume that we are already currently giving a treatment called treatment C, and we know that it has got this much proportion of treatment effect is available. Now if a new treatment comes, remember the best is we are taking best available. So this is the best available we have. If a new treatment comes, the new treatment has to prove that it has more specific treatment effect than the existing treatment. The ideal best treatment would be like this. Now this has to be proven. That's why there has to be a comparison in a randomized control trial with the standard care, with the existing care. The new treatment has to be compared, and the result should show that the specific effect of the treatment is higher. That is, the between group difference is higher, and that is the criteria for selecting for us to change our existing practice and integrate new treatment. Not just because something is new then we can take it, right? I hope you understand what I'm trying to say. So here I am proposing this 315 formula just to make things simple. To if you have to evaluate whether treatment is effective, I'm recommending that you follow this 315 formula which I have devised. Right? You will have to follow 3 principles, have to ask 1 question, and hopefully you will follow 5 commandments which I have borrowed from testing treatment website. Now, what are the 3 principles that you have to follow to determine treatment is effective or not? Now, the first principle which I would recommend is fairness. Now, fairness as a concept is we are all very familiar with. Every one of us at some point of time, or as many times as possible, have raised this question that it's not fair, right? Being fair means it's equality. People being treated unequal treatment. If somebody receives, if on a personal level, if someone treats us unfairly, say it's unfair, it's not, we are not being treated fairly. But fairness, unfortunately, is often understood when from a personal perspective. That is, when we are when we have been treated unfairly, we can really apply the concepts of fairness. But when it comes to a second person and a third person, we are finding little difficult to understand the principles of fairness. Now, I'll give an example of recently I've asked a group of clinicians, like I mentioned before, is that after discussing up to so far, is that what is the best treatment for, let us say, Bell's palsy? Almost most of them have said electrical stimulation. Now, many of you, I'm sure, are also following the same. But the question that I want to ask is, did the principles of fairness apply? That is, on what basis we have decided that we have come to this conclusion that electrical stimulation is the best treatment for Bell's palsy, right? Usually, we have just assumed that it's common practice, and we have given treatment, patient getting better, and that's that, right? So, but when it comes to principles of fairness, if you see the previous whatever that I have discussed, was it compared fairly this way to see whether it has got a more treatment effect? That is, it is producing treatment more than what a natural recovery can produce. Did we ask that question? Or is it actually producing any harm? Is it possible? Did we ask that question? I am fairly confident that we did not ask these questions, which are questions of fairness, which most often we did not ask because we just started believing because we have given this treatment, patient gotten better. We have not considered the question, what if all the treatment, all the effect patient has got is only because of spontaneous recovery or natural recovery? Is electrical stimulation actually adding value, actually having a specific treatment effect? If we have asked, then we would have gone and looked into a randomized control trial. Then we would have known the truth that no, it doesn't. That the electrical stimulation does not add anything to spontaneous recovery, meaning it is just a waste of time, and from a patient point of view, it's a waste of money and resources that they are receiving electrical stimulation. So this question of fairness must be used as a principle for us to determine effectiveness of treatment. The second principle I recommend is comparison. That is, a better treatment for us to determine, it has to be compared. One cannot say, I have given this treatment, I've learned acupuncture or dry needling, and I have given this treatment and patient has improved. That's not an evidence of effectiveness. Evidence of effectiveness is that when you given that treatment compared with another treatment, and then it is shown that it is better. Just like the graph, hope you remember, you can go back and see the graph again. Only then we can determine best. A best good treatment is something that is better than other treatment. So this whole hue and cry about newer treatment that I have learned, it is giving good results and this and that are all absolutely rubbish, because we did not compare it without a comparison with another treatment and showing that it is better in terms of specific effectiveness of that treatment, where biases and placebo effect and other effects are removed or has been cancelled out, and then you've looked clearly that it is showing a better treatment. Without that comparison, we cannot claim that one treatment is more effective than another. And so the next principle is measurement. That is, we need data to show that it is actually improved. That is, how do we say that something is more or less without measuring anything? And we all know that clinically such measurement is very, very rare. We rarely measure anything. And again, one cannot make any claim by just without even measuring it, without even say, for example, 10 patient, 20 patient, without measuring their functional outcomes, what improved and so on, then we can never say something is better. Without quantifying the effect, we cannot determine one better than another. Again, these are all very, very fundamental principles, but I have to emphasize this because it's not commonly considered while claiming for effectiveness of treatment. Next, the one question which I think everybody should ask, whether the outcomes measured matter to patients. That is, we are given a treatment and we have measured an outcome, whether that outcome mattered, that is, the outcome is important to our patient. Now, it's a fairly simple question. Say, if you take a patient with osteoarthritis knee, what outcomes they want? They want to climb stairs, they want to walk for longer duration without pain, they would like to sit on the floor, they would like to squat. These are the major outcome patient want. Now, if we want to evaluate effectiveness of treatment, we have to evaluate to what extent that treatment has improved these outcomes. That is, before giving treatment, patient was unable to sit on the floor. After treatment, they are able to sit. Before giving treatment, patient is having lot of difficulty in climbing stairs, so they don't climb. Now their difficulty is minimized and the patient is now able to climb stairs. This is what the outcome is. We cannot say the tenderness has reduced or range of motion has improved, muscle strength is good, and all sorts of things, which is not what matters to patient. We need to be, this is again, this is not a complex matter, it's very, very simple. Our physiotherapist expectations of treatment has to be in line with what patient wants, because the treatment exists to achieve what patient wants, not what physiotherapist expects to improve. So treatment outcome can only be determined by measuring it against what actually matter to patients. Now, this is the 5 commandments which I hope if physiotherapists follow this, I think physiotherapists or any clinicians, if they follow it, I think it will be towards the benefit of patient and in the larger interest of society. The first commandment, newer and popular is not necessarily better. Now, this intrinsically we think that something new is always better. Now, there is a good reason for why a lot of people believe that. Say, for example, if you're buying a TV in 2019, a newer version of the previous TV, obviously you have better features. And any technological advancements that you buy now, it would obviously have better features, better use than what it used to. So many of us often intrinsically assume that anything new is better than before. Unfortunately, when it comes to medicine, especially in physiotherapy, the treatment that comes new are not necessarily better. In many cases, it has far lesser effect than what we are having already. So we should not assume any new treatment. I'm trying out new treatment because it's fancy, because it's better and so on. New treatment are not necessarily better. On the other hand, popular treatment is also not necessarily better. That is, I'm always giving electrical stimulation to Bell's palsy. That we are always giving static quadriceps for osteoarthritis knee, and so on and so forth. So because it's a popular treatment and everybody give manual therapy or core stability exercises, everybody is giving, so it's popular. So that has to be something worthy, because everybody is doing it, then it has to be something worthy. No, it is not. And there are huge examples of why newer and popular is not necessarily better. It's popular not for the reasons it's effective. It's popular probably because it's just popular. People did not really ask whether it is effective or not. So to emphasize again, our question is it better? Not whether it's new or popular. So if you're a clinician, if somebody is inviting you to come and attend this course and there's a new treatment has come, so don't ask them whether it is new or popular. Ask them, is it better, and is it better than what we are already giving? That's important. You have to give a best possible treatment, best available treatment. So we are already giving a treatment. If someone offers come up with a new treatment, we have to ask this question, is it better than what I'm currently giving, and is it proven? right? Is it proven in a way biases and placebo effect and all other biases are minimized, right? We have to ask this question. Next, optimism and wishful thinking doesn't cut it. Now, all of us as physiotherapists, we all want our patients to get better. There's no question about it because it's intrinsic to our existence. We want our patients to get better. So we are very optimistic about patients' recovery. And also most of us expect patients recover completely. That's something good. But unfortunately, being optimistic and wishful thinking about an best outcome is not enough. We cannot simply try something new with the optimism that it will work and so on. We need to ask for evidence, right? So we need to be objective. The optimism has to be tempered with our objective views of what is actually producing, not to go just with optimistic thinking about a treatment will work. Dramatic treatment effects are rare and sometimes people get lucky. Of course, we have always heard of some treatment. Somebody says that we have had a wonderful treatment effect. Patient in 2 days they become completely alright. Not just heard, but also maybe in your own practice you have seen sometimes patients are getting suddenly dramatic treatment effects were there. But what I want you to understand here is that if it's not reproducible, if it happens once in a while, you just have to assume that people got lucky. Like just if you've seen a cricket match, some new guy suddenly hits 100 and so on, he becomes so popular. But in another one series after, he's no longer over there. He's not able to reproduce whatever that he has done in 1 or 2 matches. Now that's what we call people get lucky, right? So, and also if you are a clinician if you practice for considerable number of time, a considerable period, if you're experienced enough, then you will know that dramatic events are very rare. In your day-to-day practice, you don't get patients just, coming in wheelchair one day and walking the next week. It happens, but it's rare. So somebody claiming that dramatic effect as a common practice, you need to understand that it's not possible to reproduce such effect. And anecdotes or unreliable evidence. Now, with the popularity of social media everywhere, now you have so many patient videos are posted and patients are telling before that I was like this and now suddenly I become better, or physiotherapists themselves show explaining about their patient experience and so on. Now, I'm not questioning the credibility of how true it is because I don't know. But even assuming they are true, but they are anecdotes in a sense that it's an individual experience for one patient here and there. It's a story to maximum. That's how we should say. Even if it is true, they are not evidence of that effectiveness of treatment, right? Because in Facebook and Twitter, what people don't post is they don't post it on a daily basis. They don't post every patient's views on their treatment. Usually, the best outcome whoever received, that is what is being posted. The next patient, if they said no, I didn't get better that much, or the next 10 patient who didn't really, or who have had a average effect, or who didn't really have better effect, or even worse, someone had a bad effect. These things are often not posted on Facebook. So we shouldn't get carried away by this anecdote story talking about a patient's gotten better and so on. You have to understand it's not reliable evidence. And finally, we all have to understand, and I guess most of you already know, the expert opinion is not always right. Now, it is not just for others. If you consider yourself as expert, then you should know that you will not be right all the times. And I am pretty sure that I am not right all the times. So there's a huge amount of examples are available. You can just type expert opinion is not always right and in medicine and Google it and you will find n number of examples. So just don't rely on expert opinion. I think most people, especially young clinicians, often rely on them because they think that for them to go read and understand all effectiveness of treatment, they think it takes time and so on. So they're taking a shortcut by just relying on expert opinion, by just thinking somebody says, some expert is saying though, so he must have gone and read all these things, so we just rely on it instead of us going and reading about evidence and so on. It is not so. An expert is not an expert in everything. Some experts may be experts in their ability to communicate. They are very good communicators, but the content what they're communicating, if it's not reflecting truth, then they will be communicating something which is not true, but they would be communicating it very well, right? So we shouldn't really rely on an expert opinion. I mean, they may be right at some time, they may not be right on the other times. So relying on expert opinion is not always right. So these are the 5 commandments that I have said. I hope you will follow. And this is just for me to share that how not to evaluate effectiveness of treatment. If you don't apply all of these things, then you will know that it is always skewed on one side with clinical beliefs and biases, placebo effect, and so on. It would appear as if it is better, but it is not. I hope you got what I'm saying. So thank you very much for listening to my presentation. If you're having any questions, or if you're having suggestions and feedback, please contact me in through this mail. I hope I've explained the things that you're able to understand. Thank you very much for listening again.